Like I will always say, we are in a familiar terrain. Abnormal pregnancy is anything that deviates from the normal. You have done the normal pregnancy. As midwives, when you come in, there are certain things that will not be right. And so you need to know what and what will constitute a problem in that pregnancy that is coming up, the pregnancy you are managing. And so we are here to see those conditions. Now, when you look, most times there could be an abortion, and that abortion that will come, when you talk about abortion, you are talking about premature termination of a pregnancy that is terminated before the fetus is viable. So it could come up as abortion. It could be ectopic. There could be molar. Victoria, mute yourself. Victoria, but for mute yourself. GCUC, thank you. It could be molar pregnancy. It could even be implantation bleeding. That is when we talk about the implantation bleeding is not under abortion now. But implantation bleeding, it comes in early in pregnancy. So these are the things we need to have in our minds. So when you talk about things that could cause bleeding in early pregnancy, there could be polyps, cervical erosion. It could even be carcinoma. There could be a trauma or other disorders. Now, when we talk about bleeding in late pregnancy, we are talking about placenta previa and abruptio placenta. Another abnormality is multiple pregnancy. It comes up as that. Then, and other things we are going to discuss here, we'll have medical conditions, hyperemesis gravidarum, anemia, diabetes mellitus, pyelonephritis, and then you talk about how to prevent your malaria. It could be a condition like pneumonia when the woman is exposed, cardiac failure, thyroid toxicosis, a lot of those things. So we will look at them as the case may be. Now, bleeding in early pregnancy. If you can see the diagram there, if you look at it critically, you will see that the placenta is here, the fetus is here. Of course, I go straight to the placenta because I am dealing with a class that knows that the ovoid structure we have there is the uterus. Now, when you look at the red thing that is there, is bleeding that comes up in early pregnancy. I don't know where my cursor has gone to now. but you can see it, the bleeding there. There is a separation that has occurred and bleeding has come in. So you have seen that that blood has come all the way there. There is that separation and it has even come out. And so we say any bleeding before the 20th week of gestation is identified as early pregnancy bleeding or early bleeding in pregnancy. At 20 weeks, that fetus is not viable. It's not in any way viable. So any bleeding that occurs before the fetus is viable is said to be bleeding in early pregnancy. Now, if you look at the diagram we have here, the first one, you look at it, that is the uterus there. And of course, that is the cervix there. And you find out that this is the placenta, and that placenta is supposed to be attached to the base of the endometrium. But if you look at it here, it has separated. Now, we talked about a host of things. You come here, we are talking about ectopic. These are sites that you can have ectopic pregnancy. It could be in the tube, it could be in the ovary. In fact, the fimbriae region there, and then that is the tube there, then there is interstitial space, and then you come up here to the cornua, you can have it. You can have it in the ovary. You can have it outside in the peritoneal cavity, as you see there. And then the last one there is talking about the hydatidiform mole, the hydatidiform mole. So you look at it again, bleeding in early pregnancy talks about bleeding that could come because of the separation or because the pregnancy ab initio is situated outside the uterine cavity. It could be molar or even implantation bleeding. Dinah, can I help you? Yes, a hand is up. What can I do for you? Hello, can you hear me?
Yes,
Hello.
sister.
So somebody raised up her hand. Is it in error? Is the hand in error? Now, we talk about implantation bleeding. We all know what implantation bleeding is. It is bleeding that is defined as small amount of slight stained bleeding per vaginum. It typically occurs about the 10 to 14th day after fertilization. Implantation bleeding is common, and it is usually not a sign of any problem at all. It doesn't give any problem. It is thought to occur when fertilization or when a fertilized ovum has attempted to attach itself to the endometrial lining. So what happens is when fertilization takes place, preferably in the ampulla, and then mutation takes place, the zygote is propelled around the 14th day to the uterine cavity. When it gets to the uterine cavity, there are some villi in the morula that burrow into the endometrial lining, the basalis, the decidua basalis, the base. And it is burrowing. What is it doing? It is looking for a cavity as it burrows, that is, as it digs into the endometrium, it is releasing a pool of blood. And then that cavity is where it settles. So when it settles down there, that is embedment, that is where the villi will now be swimming to nourish the fetus in utero. It is through those capillaries that the villi will get nutrients from the mother to the fetus, and then the excretes from the fetus to the mother, the maternal circulation. So when that happens, bleeding will occur. And that bleeding is said to be slight. And it just like menstrual
Sister, please, we can't hear your voice.
doing. Hmm. Okay. Thank you. Hello. Hello, lady.
Hi.
Hi,
Hello, madam.
I want to believe my network is disconnecting and disconnecting and disconnecting. You can see the screen, isn't it?
Yes, ma, we can.
I just thought I should not go up again. I usually go up to the ICT. So what I'm saying is this lady naturally has light menstrual flow. And so she continued having it for 6 months. She didn't know she was pregnant, and she's a nurse. Until she started having funny attacks. Luckily for her, she had just newly married. And so by the time she was rushed to the hospital, she knew it was bleeding. So it was pregnancy. So what am I trying to say? It is slight. It does not constitute any problem at all. Now, when you see it, the color is light pink or brownish, depending on who. The strength of the flow is usually spotting, which may occur once or for several hours, or even up to days, as I have told you. One may notice some pink or brownish discharge when baby goes to clean up or something. But she will not need a full, maybe like sanitary pad. There could be, depending on who, cramping, which may be very light and may be short-lived. We all know this, but it's good to refresh our memories. So for whoever who may have the bleeding more, normally bleeding in early pregnancy, when it comes to implantation bleeding, it does not cause any alarm. It doesn't give any alarm, but it comes. It could flow fully like your normal menstrual flow if you have heavy flow. If you have 5 days on the norm, it could come for maybe 2-3 days. It could come one day, but very heavy. That is to show you that that pregnancy is being established. Who will read? Who is there? Yes, Belinda, read this for me. Go ahead.
Associated with the pregnancy state. 1. Cervical lesions like ruptured varicose veins.
Cervical lesions, like ruptured varicose veins, those are associated with the pregnancy. And you can see the cervical lesion here. It comes from the cervix. It comes from the cervix. You have seen the cervix there. You have seen that. The other one is the vaginal wall. And then you are viewing the cervix through a speculum. That lady is lying on a lithotomy position, and that is how you are viewing the cervix. Again, the polyp, you can see the polyp hanging out on a little thread, just hanging out. Again, this is being viewed through a speculum. Now, here is malignancy. Malignancy, cervical malignancy, could also cause bleeding. Belinda, go ahead.
Pathology. 1. Hemorrhage into the decidual basalis.
That's it.
2. Necrotic changes in the tissue adjacent to the bleeding. 3. Detachment of the conceptus. therefore, the above will stimulate uterine contractions, resulting in expulsion.
So, there could be hemorrhage from anywhere that is dripping into the decidua basalis. Remember when we started, I told you that for implantation bleeding, the villus burrows into the decidua basalis for it to be established. So, to be embedded, that's the midwifery language. So when that happens, and there is bleeding from anywhere that is going between the placenta and the decidua basalis, there's bound to be necrotic changes in the tissues that are adjacent to that structure, that are adjacent to the bleeding. And that constitutes a problem. And what is the problem it constitutes? Gradually, because it is interfering with the functions of that organ, detachment of the conceptus begin to occur. How does the conceptus detach? It detaches by the placenta. If we go back, what's it here? Let's go back. Good. Here, if you remember, in the first diagram where we have abortion, you will see the conceptus being detached from, who is this? Asama, mute yourself. Please don't let me ask that everybody be muted. Please mute yourselves. I like that liberty so that if one has to talk, the person can talk. So if you look at the diagram that is talking about abortion, you will see the detachment there between the basalis and the conceptus. The very dark black, there is a gap there, that's the separation. So that's what we are talking about. When there is bleeding, and that bleeding is flown or it concentrates around the decidua, the muscles there, the tissue there will necrose. And when there is necrosis, there's bound to be detachment. And of course, what is detaching? It is the conceptus. So all that we are talking about will stimulate uterine contraction, resulting in expulsion of the conceptus. The simple thing is that something is wrong somewhere. And once the detachment starts, the master gland has been informed. This visitor that came in, there is a problem. And so the visitor should be sent out. And the master gland will now send, who is the master gland that I'm talking about, please, class? Hello? Who is the master gland?
I mean the distance, the hypothalamus.
Hypothalamus what? The anterior pituitary gland. The pituitary gland is the master gland. You are correct. You are talking about the brain and all that. Okay. Now, that's this language here. I don't know how it came up here. Is in the wrong place. When we go further, we will see where it is. That place is the wrong place. It's not supposed to be there. I will quickly bring okay. We have abortion. What is that in a pan? Hello? Can you hear me?
Product
Yes,
church.
ma'am.
What is that in a pan?
An abortus.
Product of conception.
Products of conception. What does it look like?
A fetus. A frog.
That is a fetus looking like a mosquito. Now, what is pregnancy? Termination of pregnancy before the fetus is capable of extrauterine life. It could be 20 weeks, it could be 24 weeks, as the case may be. But the important thing is that the pregnancy is still so young that this fetus will not be able to survive in extrauterine life. There are many types of abortion. And you all know it. I think you even have a song you sing for it. You have when we talk about the spontaneous, it is threatened, isolated in the sense that it is called isolated. Because it comes on its own. It is threatened. And when it is threatened, we all know that it may go to term. Inevitable. When it is inevitable, there's nothing you can do. That abortion must complete. And when the abortion is inevitable, we all know that it can either be complete or incomplete. It can be missed abortion. It can be recurrent abortion. And depending on how it is managed, it could be septic. So if you look up here to the diagram, threatened abortion could go to term. The cervix could close. And then the other diagrams there are talking about the other types that cannot be helped. Now, you have the induced. When a pregnancy is induced, the induction could be legal or illegal. Who is there? Okay, Belinda, still read what is under that fetus.
Not human, just a fetus. How long until we justify killing the old, the sick, any person without a champion?
That's it. That is always the defense that doctors give, and of course some midwives. They will tell you, oh, it is not a human being. If they curate it early in pregnancy, they will tell you it is a blood moon. And then those who do it later will tell you it's just a fetus. And I always have this illustration. that doctor was a fetus in the mother's womb. If he or she was curated out or even brought out by destructive operation, would the person have been there? Please answer me.
No, ma.
No.
ma.
No, ma.
No, sister.
A human
No,
being in utero is called a fetus. And that's the truth about it. Now, when you say it is just a fetus, are we going, the question here is saying, do we justify this until you have killed an adult who does not have anybody to speak for him? Because the fetus cannot talk for itself. And the fetus does not have anybody to talk for her or him. It is an isolated plan. The woman could just go out, my parents will kill me, and do it without the knowledge of the parents or even the man responsible. The man responsible may dish out money and say, go and remove it. I am married. I cannot withstand it. I'm not ready for marriage now. I am still a student. I don't have a job. I graduated. May God help us. Now, the abortion tree, of course, we know it. Like I told you, the abortion would come, it could be spontaneous. When it is spontaneous, it is threatened. And when it is threatened like that, it could go to term. This diagram is wrong. Under the threatened abortion, I don't know where my cursor is going today. Okay, it's correct. You can see where under threatened there at the middle, it went to term. It could go to term. It could be inevitable. And when it is inevitable, it could be incomplete or complete. When it is complete, you may have habitual abortion. Habitual abortion. When it is incomplete and in the facility, there will be no problem. But where it is incomplete and mismanaged, it could be septic. Just as you have the induced. Therapeutically, it's okay, but criminally, it could go down and it is septic. Then you have the missed abortion. Yes, Belinda, go ahead.
Etiology. 1. Genetic factors. 2. Endocrine and metabolic abnormalities. 3. Infections.
Those are the things that can cause abortion. Genetic factors, there are very many. Endocrine and metabolic, there are many too. And then, of course, infection. So when you look at this, you see, recently there was in the news a woman that has 2 uterine cavities carrying a pregnancy. I don't know whether it is still in my phone, whether it's in this phone. I'll look for it. And when we meet again, I'll let you have it. So it happens. So you have this one here, the first one, the A, has 2 different uteri. The B, you can see how it is curved. The uterus is like, how will I call it? Is it like a T-junction? Y? And then the C has 2 cavities. And then you have the D, which is too small for anything. Then you have the immunologic disorders, autoimmune disorders. Continue, Belinda.
B, alloimmune disorders. C, antifetal antibodies. D, maternal medical illness. Under maternal medical illness, there is blood group and incompatibility. There is there is environmental factors and unexplained.
And unexplained factors. So I give you people assignment. You will go and look for all this. And when next we meet, we will discuss how what the causes are and how they cause the problem. Okay. Who else is there? Esther.
Yes,
Esther Akwalu, yes. Let's hear you. Mechanism of miscarriage, mechanism of abortion.
Mechanism of abortion.
Are there two Esthers? The one that is reading is the one I want.
Before 8 weeks, the ovum surrounded by the valley with the decidual coverings is
You
expelled.
said that it's surrounded by what? Villi.
Decidual. Surrounded by the villi
Go ahead.
with the decidual coverings is expelled out intact. Sometimes the external os fails to dilate so that the entire mass is accommodated in the dilated cervical canal and is called cervical miscarriage.
So you see the problem from the first week, the ovum that could be surrounded by the villi, what do we call that decidual covering? There are three types of decidua. I've told you about the decidua basalis. What do we call this decidual covering? Who can give me the name? Hey, midwives. Should I give you that as an assignment?
Decidual capsularis.
God bless you. Give her a round of applause. Give her a round of applause.
Wow.
Thank you. And what is the third decidua called? The capsularis, the basalis, and the what?
It's the virals.
That's it. Thank you very much. So this is what happens when abortion, you have the blighted ovum there. Now continue, Esther.
8 to 14 weeks. Thus, expulsion of the fetus commonly occurs, leaving behind the placenta and its membranes. Point 2. Beyond 14 weeks, the process of expulsion is similar to that of a mini labor. The fetus is expelled first, followed by the expulsion of the placenta after a varying interval.
Now, you look at what you have just read. 14 weeks is how many months?
3 months, 2 weeks.
3 months. And somebody will tell you it's just a blood mold. They said the process is like a mini labor. The fetus is expelled, and after a while, the placenta is expelled. Hello. So as midwife, I want you to think critically. If you are one of those used by doctors to do this, don't do it again. 3 months, placenta is formed. 8 weeks is 2 months. Even if it is a day. Go ahead.
Threatened abortion, miscarriage, sorry. It is a clinical entity where the process of miscarriage has started but has not progressed to a state from which recovery is impossible.
Yes. Remember we said threatened abortion could go to 10. Who can tell me the difference between miscarriage and abortion? Yes, Deborah. The difference between miscarriage and abortion. There's no difference. Can you hear me?
Yes, sister.
There's no difference.
Yes, ma'am.
So when you said threatened abortion, you said, oh, sorry, miss. Okay, you were trying to say what is written there. There's no difference. Now, the clinical features of threatened abortion. You find out that there's, okay, go ahead.
Short period of
Amenorrhea.
2, yes, please. 3, mild bleeding, that's spotting. 4, mild pain. 5, PV, pregnancy tests, HCG, positive.
Pervaginum. When you do an examination per vaginum, you will see that the cervical os is closed.
It's closed.
Then you have pregnancy test, of course. You will have the HCG will be positive. Ultrauterine sound. You will have viable intrauterine fetus. And then the serum progesterone. Now, I want to tell you, say something about the HCG. The HCG is not something we hold on tenaciously because even after expulsion, 3 weeks after expulsion, HCG could still be in blood circulation. So 3 weeks after expulsion, somebody could go for test and they tell you you're pregnant. Or they tell you the HCG is present. And then you begin to think the pregnancy is still there. No. Now, management, you reassure, you give the person rest. Diazepam 5 milligrams morning and evening. And then after a while, you repeat the ultrasound investigation you did. Now, the other Esther, read. Where is she?
Inevitable. Sir, please, I'm here.
Oh, go ahead.
Inevitable abortion. Clinical features. Short period of amenorrhea. Heavy bleeding accompanied with clots may lead to shock. Severe lower abdominal pain. PV. Open cervical os. Pregnancy test, that is HCG. Positive. ultrasound on viable fetus and blood inside the uterus.
Non-viable fetus.
Sorry, non-viable fetus and blood inside the uterus. Then the management, fluid, that's blood. Mitigate. Sister, please, can you help me?
Metagene, 0.2 milligram.
0.2 milligram. Evacuation of the uterus. Medical or surgical?
Medical or surgical. So this is where you have examined and you are convinced that the abortion is inevitable. So having taken this, seen all these features, you know that that abortion is inevitable. And so where it is inevitable, you manage it by giving fluid, which is usually blood. You give, depending on what you are using, metagene, you do evacuation, or you can use a IPAS materials to do it. We all know IPAS, isn't it?
No.
Huh?
No, we don't know.
Please, we know. Some of us know. Yes, we know.
God bless you, my dear, because I would have been frightened that midwife. In other words, if you don't know IPAS, then you do not know anything about
Cut and pack.
abortion care.
Yes.
Makes sense.
Continue, Esther.
Next one. Complete abortion. Expulsion of all products of conception. Cessation of bleeding and abdominal pain. PV, closed cervix. Ultrasound, empty uterus. Management. US. Anti-gamma globulin.
Yes, one of the causes of abortion is rhesus incompatibility. And so when that happens, it is wise to give anti-D gamma globulin. Rhesus incompatibility is very common. Most people that are incompatible, if they have the first pregnancy, that could be okay, but they will not need to go immediately into pregnancy. I have somebody I know had the first baby, but that baby suffered so much of hemolysis and a lot of things, even though the baby survived. Now, the advantage, who is that? Please mute yourself. Kedra or whatever you call yourself, mute yourself. If the name sounds like your own, please, you I'm talking about. I would demand something. So what happened in that case was, when that happened, by the grace of God, they went away and didn't bother. They didn't go back to check. Just thought, okay, it was one of those things. Am I to ask that everybody be muted? Thank you, Garden City. God bless you. Now, I always like class to be interactive. when you read, I am preparing you people for your next level class, which is academic writing. And that's why I like you people at this level to read. But you're making too much noise, please. I don't know. You will give Garden City University too much work. The person that is there is the person I'm calling Garden City University, because it will mean when I call your name, you're muted, you are unmuted or something. Please. So what happens is that when it is like that, in this particular case, as I was telling you, they didn't know, but by the grace of God, they didn't even think of it. The man, a pastor. So it was 5 years later that they decided to make another baby. You can imagine an interval of 5 years, problems came up. That was when they now knew that, oh, if they had known, they would have taken the anti-D immediately after the other. But
Just like that. Come back and take the rats on the floor. The peg is on the floor.
who is the class rep? Can you please tell this person to mute herself?
Shirley, Madam Shirley, mute yourself, please.
So when we talk about complete abortion, it comes that way. Then you have the incomplete there, and then you have the complete there. You can see that while the other one is still looking bloated, this other one is empty. Shirley, can you please mute yourself? Thank you. Yes, Esther, continue. Mr. Abortion. Has Esther been swallowed up by network? Mercy, go ahead. Oh,
Hello,
the okay. Yes, Zaria, what can I do for you? Adam Zaria, what can I do for you?
Ma, please, I have a question.
Go ahead.
Please, about the anti-D. In case the woman has delivered first, she didn't notice it, and the subsequent one, she keep having the miscarriage. What can you do for her?
Sorry?
The first pregnancy was successful, and the child is alive, but the subsequent ones, the woman has been having miscarriage, the woman can deliver again.
I take her to a doctor. Let that be administered. She should take the anti-D. Gamma
When
globin.
she became pregnant?
No, she doesn't need to be pregnant. If she has experienced it after the first baby, she has the second pregnancy, and she lost it, she should take it. She doesn't need to be.
Okay.
She doesn't need to wait until she will not even be able to deliver, because the
yes, she had to miss
sensitized. You say she has what?
Yes. After the first child, she had to miscarriage it in 2024.
Yes, she could continue.
And she
If she
was
had a miscarriage and you
negative
know
blood
her,
group.
send her right now to a doctor so that she can take that thing. You can even prescribe it for her to help her.
Okay. Okay,
Esther,
thank you very much, ma.
Yes,
Hello, ma.
Rena. Yeah.
Hello, ma.
Yes.
Please, we learned the anti-D is within 72 hours. If the person doesn't take it within 72 hours, when they take it, it doesn't work again. And the question she's asking, maybe a year or two has come and the person is now experiencing it. When they give the anti-D again, will you reverse everything back to normal?
Yeah, what I'm telling you is that anti-D should be taken when the situation is observed. So if you are not going to take the drug and begin to give her, that is not yam. You have to read and see what the indications are, the side effects, the usage, the route of administration and everything. You understand what I'm saying? The important thing is that drug should be taken. And like I said, it's not cocoa that you just dish and give her a drink. You have to read the do's and the don'ts before it is administered. And that's why I first of all said, let her see a doctor. But an anti-D the woman could go suggesting to the doctor, and I think the midwife can prescribe it. Whatever, the important thing is get the literature and read it. Hello?
Hello, Prof.
Okay.
Hello, Prof.
Yes, please.
I think what we want to understand is that if the woman has been sensitized, the blood has already been sensitized, and she takes the anti-D, will the anti-D reverse the sensitization? I think that's the question we want to understand.
The truth is, Professor Duke did not manufacture the drug. Neither is she selling it. Hello? But what Prof is saying is, get the drug, get the literature, and you will know what to do and when to give it. What is important is that drug must be taken in that condition. But when exactly, the leaflets will tell you. Have I said something? Hello, are we understanding ourselves?
Yes, sister.
Yes. Oh.
Okay. Esther, please continue.
Prof, please, I have a question.
Go ahead.
Please, I met one woman during an ANC visit.
I can't hear you.
Abortion.
After the hello.
What's the problem with abortion? Go ahead.
Prof, please, can I go ahead?
Go ahead. I say go ahead. Yes.
Okay, so I met this woman, and this was her 5th pregnancy, and all the children are okay. She has given birth. Nothing is wrong with the case. And with the 5th pregnancy, when I suggested we should take the anti-D, she wasn't in agreement.
Why did you suggest anti-D at the 6th pregnancy?
The 5th pregnancy, because when we did the blood incompatibility, it wasn't the husband and her own weren't the right ones. So we suggested
is the man not the father of the other 5 children?
The same father. The same
but the
man.
reaction came after the 5th baby.
Yes, please. When she came and we did, and then the blood was that we requested the husband to come to and then we'll test. So we got to realize there's blood incompatibility. But she said her children, or she delivered and nothing happened to them.
So what happened? She refused to take it.
Yes. So we referred her to see a doctor.
Actually, there are a lot of things. As you're talking now, a lot of things are going through my mind. For rhesus incompatibility that I have known and nursed, the first baby could come out alive. But even then, intensive care unit will do a lot of things.
Okay.
After that, the body is sensitized and subsequent pregnancies become a problem. I am sorry to say this, but I will say it because that is what is on my mind.
Okay.
If 5 children have come from her husband and no problem, they become a question sign. Is the 6th pregnancy from their husband? I am not saying, I'm not accusing her. I'm only wondering.
Yeah.
Because for rhesus incompatibility, if it is severe and the pregnancy is aborted, the first one, it becomes a real problem.
Okay.
But consolation comes. The man, the woman, they are comforted if the first baby is delivered normally, but there will be hemolysis.
Okay.
There's bound to be hemolysis. And then the woman herself, her system goes wild. Wild in the sense that any baby that enters is attacked seriously.
Okay.
The only thing that will allay it is the anti-D. Was the woman taking anti-D for all other pregnancies and she didn't take for this?
Yeah.
Another thing again will be, this is an assignment for all of us to go back to investigate.
Okay.
Knowledge is dynamic. Can the same couple with incompatible rhesus have a number of children apart from the first one before the reaction? That's what we have to find out. Otherwise, where is that pregnancy from?
Okay.
What we are doing now is like we have a case study, and that's the case we are studying. So feel free. Yes, Salamatu.
Thank you, Prof.
Ma, please, with that one, for me, I think that before the woman will get a reaction, it's during the separation of the cord. That's where if the mother and the baby blood mix, that's where the reaction comes. So maybe during her first 5 children, during the separation of the cord, there wasn't any mixture of blood. That was why all those babies were successful. Then maybe the last child before the pregnancy she's carrying, during the separation, there was a mixture of blood. So to my understanding, I think that's the cause. Because before this thing, the woman will get the reaction. If the mother, the husband, so it's possible that there are some women, they will come to the ward to deliver, grab that cyst. And you see that the mother blood group is negative, the husband is positive, and all the children are alive. And even those days, the olden days, they were not doing blood group. But you come to realize that their children were alive. And it was due to the separation of the cord. So for me, I think that the first 4 children, maybe the 5th child that maybe she had the reaction. So maybe the 5th child, during the separation of the cord, that maybe there was a mixture of blood. If otherwise, the separation was done well and there was no mixture of blood, it's possible that she can be delivering, the mother will be negative, the husband will be positive, and all the children will be alive. So that's what I think.
Can we help ourselves instead of arguing to go back and find out? Let's go back and investigate. Let's go back. We need, for me, this is new and I need to go and investigate.
Okay, woman.
Is Esther there to continue? Thank you for all your contributions.
Yes, ma'am.
Esther, continue. Belinda, hold on. When we continue like this, we won't finish what I brought. Esther, continue, please.
Please abortion. Yes, ma'am.
Hello. Features of missed abortion. Okay, Belinda, Rena, please, can you read?
Yes, please. Missed abortion. Futures. 1. Gradual disappearance of pregnancy. Symptoms, signs. Brownish vaginal discharge. Milky milk discharge, excretion, sorry. Pregnancy test, negative, but it may be positive for 3 to 4 weeks after the death of the fetus. US, absent fetal heart.
What is US?
That's ultrasound.
Okay.
Absent fetal heart, pulsation, complications,
Absent fetal heart pulsation.
Pulsation. Okay, thank you. Complication, infection, into brackets, septic abortion. Then DIC. We come to treatment. Wait 4 weeks for spontaneous expulsion. Evacuate if 1, spontaneous expulsion does not occur after 4 weeks. Expulsion, infection. So when you evacuate if spontaneous expulsion does not occur after 4 weeks. Then infection can set in, then DIC, then you manage according to size of uterus. Then uterus less than 12 weeks, dilatation and evacuation. Then uterus greater than 12 weeks, try oxytocin or PGS.
What is PGS? I'm asking the class.
Prostaglandins.
That's it. Now, there is something I want to talk under the treatment. You're asked to wait for 4 weeks for spontaneous expulsion. Now, if after 4 weeks, expulsion is not spontaneous, and there is probably infection. And where there is infection that has stopped the spontaneous expulsion, I say where there is infection that has stopped spontaneous expulsion, please, the dilatation and curettage should not be attempted until the infection is controlled. Hello? Until the infection is dealt with. Where the infection is controlled, you now begin to manage according to the size of the uterus. If the uterus is less than 12 weeks, then there's bound to be no infection there. So you can dilate and then evacuate the products. But where it is more than 12 weeks, you don't want to attempt curettage. You don't want to put anything there, because if there is infection, it is very sure that the endometrial lining, the uterine muscles, the uterine cavity will be susceptible to easy perforation or to perforation. I may not say easy perforation. So you must be careful there. So you don't just go nursing blindly. We must be very careful. Yes, Esther.
Yes, ma'am. Yes, ma'am.
There's septic abortion on the board for you. Hey. Esther, you are muted. Is everybody muted? Okay.
No, please.
Then why is Esther muted? Okay, Rena, go ahead and read.
Okay. Septic abortion. An abortion complicated by infection. Symptoms. 1. Abdominal pains. 2. Fever. 3. Vaginal discharge. Into brackets, foul smelling. Signs. Sick looking, febrile or jaundice. 2. Tender uterus. 3. Offensive vaginal discharge or bleeding. 4. Cervix is usually soft and may be dilated.
So when we say septic abortion, we understand that there is infection, isn't it?
Hello.
Yes, sister. Yes, ma'am.
We all know there is infection. And once there is infection, there's tenderness. And it is because of that tenderness that I am saying we should not move into curettage. We shouldn't introduce any forceps into the uterus for fear that there could be perforation. Go ahead, Rena.
Clinical guiding. Grade 1. The infection is localized in the uterus. Grade 2. The infection spread beyond the uterus to the parametrium. Grade 3. Generalized peritonitis or endotoxic shock or jaundice or acute renal failure.
So that is 8. Even with abortion, it is graded. When it is grade 1, it's just the uterus that is affected. When it is grade 2, the infection has spread. It has gone beyond the uterus. It's no more confined in the uterus. And when we talk about grade 3, it has become a higher problem. When you talk about peritonitis, endotoxic shock, you're talking about septicemia there. The system is affected. Go ahead, Reina.
Okay. Complications of septic abortion. Immediate. We have both the immediate and the late. So immediate. 1. Hemorrhage. 2. Peritonitis. 3. Pelvic abscess. Endometritis. Then 4. Septicemia. Then 5. Septic stroke, hemorrhagic shock. Then the late, we have PID. 2. Pelvic adhesion. Then 3. 2 degrees infertility.
Secondary infertility.
Secondary infertility, sorry.
So these are the complications. Immediate and remote complications. When there is hemorrhage, when there is peritonitis, and it is not properly treated, it could cause PID. As it continues, pelvic abscess, endometritis, they could become adhesions. The internal organs may adhere to themselves. And of course, that septic abortion, that infection could cause secondary infertility. Yes, Reina, management.
Management. 1. You do resuscitation, IV fluids, Ringer's lactate or normal saline. 2. Insert urethral catheter. Then you monitor inputs and outputs. 3. Blood grouping and cross matching. Then 4. Antibiotics, preferable cephalosporin. If not available, pardon?
Go ahead.
If not available, ampicillin and metronidazole. 5. Prophylactic gas gangrene serum of 8,000 units and 3,000 units of antitetanus serum. Then 6. Evacuation. Then 7. Hematics.
So you see the severity of infection. After giving all you have given, you must also administer anti-gas gangrene serum. And not just that, you will go ahead to administer anti-tetanus. Please mute yourself. So when a woman comes to you, you have to counsel every pregnant woman in your antenatal talk to them. If there be any problem, the pregnancy is threatened at any stage, expelled at any stage, they should come to the hospital. Because they may be outside the facility and there is an infection they do not know, which might be life-threatening. Go ahead, Reina.
Reoccurrent miscarriage. Definition. Defined as 3 or more consecutive pregnancies losses. Other names: habitual abortion, habitual miscarriage, reoccurrent abortion, reoccurrent miscarriage. Etiology can be established in only 30%. Genetic factor, endocrine factor, anatomic causes. congenital abnormalities, incompetencies, infection causes, hemoglobologic problem, immunologic problem, sorry.
Immunologic problems. So you see wahala with, okay, I had told you earlier, I said abortion and miscarriage are the same thing. The thing is that most times the layperson decides to use the word miscarriage, while medically the word abortion is preferred. But I decided that these two should come so that you know. So that is it there. For these conditions, there may be genetic factors, anatomic factors, endocrine factors. And when you talk about anatomic factors, like we saw the other side, it's usually congenital problem. Congenital problem, incompetence, cervical incompetence should be that. And then infectious causes. When we talk about cervical incompetencies, most time it comes up as management. Susanna, mute yourself. It comes up as management. Somebody may have had, like they said, 2 or 3 abortions. And then a Shirotka stitch is put. That patient should be advised to be close to the facility. But that stitch could be put and nothing is said to the person. The person goes and contraction starts there. You don't know how severe the contractions could be. There may be rapid contractions, and then the Shirotka stitch is removed. Removed not by a skilled personnel, removed by the contractions crudely. That only goes to cause damage to the os, the cervical os, and increase more problems. So that's what I mean by management. Stella, can you help us please unmute yourself? So that is that. Yes, somebody was asking a question. Go ahead with your question. Or do we continue? You can go ahead and ask your question.
Yes, Prof, please. My question was the initial part of the lesson, the definition of abortion. In our diploma training, we were taught that any miscarriage before 28 weeks is classified as abortion or any expulsion. But today you are teaching us before 20 weeks or 24 weeks. But we know even 26 weeks, sometimes it's very difficult for the fetus to survive extrauterинely. So the 20 weeks, no, and the 24 weeks, no. Even in our wards currently, most of us still go by the 28 weeks.
Let me tell you something.
Okay.
In all the classes I have taught, and even in this class today, I told you, I said, before the fetus is viable. Before the fetus is viable. There's something I want to tell you is that knowledge is dynamic. If you go into the net today, everybody is talking about 20 weeks, 24 weeks, 20 weeks. But I was taught 27th week. That's the same thing you're talking about. So you define, to be on the safe side, I always like to say termination of pregnancy before that fetus is viable. That is, before the fetus is capable to survive extrauterine. So that is what I use. But most books will tell you 20 weeks, 24 weeks. Most slides in the net. And if knowledge is viable and we have to follow, we follow that, what is said. But the truth in all is there are some children or some fetuses that could survive after 20 weeks. There are, but maybe the range is not much. So probably we should be more comfortable using before viability, using the word viability. Are you okay with that?
Yes, ma. Thank you.
Yes, Asama.
Okay, sister, good morning. Please, so I want to ask, if a client is pregnant and is about 24 weeks and prompts set in, the prompt always comes even when the client is being admitted and there was a bed rest. IV infusions were setting.
Is that noise from you?
No, please.
Helena, go ahead.
A client who is 24 with prom has been admitted with IV infusion set on. The client went on up to 25 weeks. A scan was conducted and the amniotic fluid was 0 centimeters on the baby. So in this case, doctors discussed with the client that, okay, this baby can't survive without amniotic fluid. And there was a termination, that is induction. Baby couldn't survive. With this client, in her next pregnancy, is it good for the client to go for cerclage? And please, I want to know, can cerclage
also help? Is it good to go for what?
Cerclage.
Yes,
cerclage, yeah. And can the cerclage also help the client prevent prom in the next pregnancy? Thank you.
Whether it can help the client to do what?
To prevent prom in the next pregnancy.
Commence what?
Prevent prom from the next pregnancy.
Well, that last word, I didn't hear it too. Present what? Spell
prevent it. Premature, what do you call it?
Oh, did you say prom?
Yes, please.
Okay. Well, that fetus was induced, isn't it?
Yes, please.
It was induced. It was not spontaneous. Well, it is ideal for her to tell the midwife what it was. For a premature rupture of membrane, yes, it has to be said, but it is necessary to indicate that the premature rupture of membrane was not spontaneous. The premature rupture of membrane is not the problem, but the oligoamniotic fluid is the problem. Are you following?
Yes, sister.
The oligo is the problem, not the problem. The problem is not a problem, it's the oligo.
I will get up and leave.
So that is that. And there's no how she can come without mentioning that to the midwife. She has to. Because
Sister, please, so
yes, please.
the prom was spontaneous. It happened at the facility, so the prom was spontaneous.
I thought you said it was induced.
No, the prom was spontaneous, and the client was admitted for almost 2 weeks.
Okay.
Bed rest with infusions.
Okay. Before she was discharged.
Yeah. The client was admitted at the facility with IV infusions to replace the lost amniotic fluid. But after a week or two, a scan was done. And the scan identified that there was no amniotic fluid on the baby.
Okay.
So in this case, doctors counsel the client that if there is no amniotic fluid on the baby, probability of the baby surviving in utero is small, and the baby is 24 weeks.
I now get the picture.
So in this case, there have to be a termination, or they buy time. The amniotic fluid on the baby was 0 centimeters. Nothing was on the baby.
So what do you mean by termination or buy time? What time are you buying?
Like maybe it was a discussion between the doctor and the client that maybe if this baby cannot survive, so if you wish, you wait to see whether the baby can be in utero for some time before it goes off, or you would like us to induce you to bring out the baby.
That will be taking unnecessary risk.
Yes. So the client went on with the induction to be done to take out the fetus. So I'm asking, if this client comes to your facility again with a pregnancy, as a midwife, is it advisable to cancel the client with cerclage to be done so that prom will not occur again? And I'm asking if it is possible.
That is not what you will ask a question, because why are we there? Why are we studying abnormal pregnancy? You are studying abnormal pregnancy because you want to forestall further problems. So with her next pregnancy, when she comes, the prom has to be there, but detailed history, because you want to find out what must have caused the premature rupture of membranes, and why it is that after management, her body could not produce more amniotic fluid. Are you following my argument?
Yes, sister.
Yes. So you have to do that so that in that next pregnancy, you are watching out. Because people do come, or are we going to say it depends on the quantity of fluid that went out? Even then, that is a very important thing to look out for and to manage. Yes, the Rubaba too.
Okay, sister, good morning. I wanted to add to what you said. Like, when the client comes back with a pregnancy, we can't just go ahead and cancel the client to go ahead with cervical cerclage unless the client has been diagnosed of incompetent cervix. We can't just go ahead and just say, okay, because of what happened earlier, then I think it's best you go for cervical cerclage unless the client has been diagnosed.
So she should go for cervical what?
Cerclage. That's what the lady was saying.
Is that what she was suggesting?
Yes, please.
No, for one, no. I was rather interested in the history. Let the history be detailed. You can't judge from just one situation, please. I didn't get that. You can't judge from just one condition. But the history must be taken, clearly written down, recorded in black and white. That's what I was saying. Can we continue? Remember to, if you are still there, read.
Ectopic pregnancy. It's one in which the fertilized ovum is implanted and develops outside the normal endometrial cavity.
Are you looking at that diagram?
Yes, sister.
You will see the blood clots inside there. You can see the uterus the other side. The right fallopian tube is the one that is affected. The bowels are there. Go ahead.
Incidence increased due to PID, use of IUCD, tubal surgeries, and assisted reproductive techniques. 2, ranges from 1:25 to 1:250. Average range is 1 in 100 normal pregnancies, late marriages, and late childbearing. That's 2%. That's an ART is equal to 5%.
Recurrence rate.
15% after first degree,
after first ectopic pregnancy.
Okay,
and
and
then 25% after two
ectopics.
In other words, when you have one, you are susceptible to another. So you see that you can have it everywhere, even in the fimbria, you have it, in the ovary, anywhere. In the abdominal cavity, it is there. Pregnancy can be implanted anywhere in the body. Etiology. Who can help us read? Mamele, Abigail.
Etiology. 1. Tubal factors. Example, salvinages, previous tubal surgery. 2. Zygote abnormalities, chromosomal abnormalities. 3. Ovarian factors, into brackets, ovum into contralateral tube. 4. Exogenous hormone, into brackets, oral contraceptives. Other factors like endometriosis and IUD.
So these are the possible causes. Go ahead.
Fate of tubal pregnancy.
I
1.
hope we all remember that ectopic pregnancy is otherwise called tubal pregnancy.
Yes, please.
But most people do not like to use the word tubal pregnancy because you could have it outside the tube. Go ahead.
1. Tubal mole. Thus, the gestational sac is surrounded by a blood clot and retained in the tube. This may remain for long period in the tube and form so-called, into brackets, chorionic ectopic pregnancy, or they may be gradually absorbed, that's involution. 2. Tubal abortion. This occur more if ovum have been implanted in the ampler portion of the tube. Separation of the gestational sac is followed by its expulsion into the peritoneal cavity through Please, your screen has been taken away.
Abigail, are you back?
Yes, please.
Go ahead.
I'll read it 2 again. Tubal abortion. This occurs more if ovum had been implanted in the ampler portion of the tube. Separation of the gestational sac is followed by its expulsion into the peritoneal cavity through the tubal ostium. Rarely, reimplantation of the conceptus occur in another abdominal structure, leads to secondary abdominal pregnancy.
So we are told that rarely do we have reimplantation of the conceptus in other sites. And if we do have, it will lead to secondary abdominal pregnancy. In other words, once it happens, it does not happen again in that particular site, but ectopic pregnancy may reoccur. What is this one? Okay, go ahead.
3. Tubal rupture. More common if implantation occur in the narrower portion of the tube, which is the isthmus. Rupture may occur in the anti-mesenteric border of the tube. Usually profuse bleeding occurs. That's intraperitoneal hemorrhage. If rupture occurs in the mesenteric border of the tube, broad ligament hematoma will occur.
So if you look at the diagrams here, the diagrams we have. This is the ovary there. This one is the fimbria. So that if definitely this will rupture, and when there is rupture, there is going to be into the peritoneal cavity. And that's the same thing in different parts. If the rupture is close to the uterus, then it could bleed, but most times there is no bleeding. Let's go to the signs and symptoms. Most times there's no bleeding. Go ahead. Presentation.
Presentation. Early symptoms are either absent or subtle. Clinical presentation of ectopic pregnancy occur at a mean of 7.2 weeks after the last normal menstrual period, with a range of 5 to 8 weeks. The most common presenting symptoms that are suggestive to ectopic pregnancy are clinical trial.
The triad. Number one, you find out that there is amenorrhea between that period. Between the 8 weeks, 5 to 8 weeks, there is amenorrhea. Then you have abdominal pain. Then abnormal vaginal bleeding is not a common feature. It's not a common feature, but it may be there. From your observation, I do not know, but there is amenorrhea. She comes in with abdominal pain. There may or may not be abdominal bleeding, but what happens commonly is fainting attacks. Continue, please.
Signs. The patient looks quiet and conscious, perspirate and looks blanched, pallor, features of shock. Abdomen feels tense, timid, and tender. No mass is usually felt. Shifting dullness present. Pelvic examination reveals branched white vaginal mucosa. Uterus seem normal in size or slightly bulky. Extreme tenderness on fullness palpation or on movements of the cervix. No mass is usually felt through the fullness. The uterus floats as if in water. Unruptured tuber ectopic pregnancy.
So you see those signs as the actor, you have seen all those signs that have been enumerated. Nobody has talked about excess bleeding. Are we following? But there are terrible signs that are there, symptoms.
Symptoms. Presence of delayed period or spot with future suggestive of pregnancy. Uneasiness on one side of the trunk, which is continuous or at times colicky in nature.
It could be continuous, that uneasiness, or it could be colicky in nature.
Signs. Uterus is usually soft, apposital small, walls circumscribed. Tender mass may be felt through one funness separated from the uterus.
The uterus is usually small, appositile small, well-circumcised tender mass may be felt. You feel it on one side of the fornix, separated from the uterus. Then there is a bulge here. Vida, mute yourself. There's a bulge here. It is not in the uterus. It is seen in another cup. Continue.
Chronic or old ectopic. Symptoms: amenorrhea, lower abdominal pain, vaginal bleeding. Signs: The patient looks ill, pallor, pulse persistence high, even during rest. Features of shock. Temperature may be slightly elevated.
Symptoms of shock. Temperature slightly elevated.
On abdominal examination, tenderness and muscle guard on the lower abdomen, especially on the affected side in the striking features. Mass in the lower abdomen may be felt, which is irregular and tender. Calling sign, dark bluish discoloration, if found, suggests intraperitoneal hemorrhage.
If found, it suggests intraperitoneal hemorrhage. Then diagnosis.
Diagnosis of ectopic pregnancy. Pregnancy test, that's positive, which is 82.5%. Hematocrit, white blood cell counts. A negative test does not rule out an ectopic gestation.
If you do a pregnancy test and it is negative, it doesn't rule out ectopic, but all other signs are there.
Subacute chronic ectopic. Blood examination. Cardiocentesis. Estimation of beta HGC. HCG. Sonography. Color Doppler sonography. Combination of quantitative beta HCG values and sonography laparoscopy. Dilatation and curettage, please. Serum progesterone and then laparotomy.
So that is that. Then the management. But there's something I want to say about the symptoms. No matter how masking those symptoms are, a telltale symptom is the abdominal tap. The one that we saw there, they said is like a fluid, dark. That is, once you see that, you are convinced it is ectopic. Continue with the management.
Management, emergency treatment, immediate surgery or anti-shock, that's warm and oxygen is given. And then 2, surgical treatment, laparoscopy techniques. And we have the medical treatment, supportive treatment, that's antibiotics, iron therapy, and a high protein diet.
The truth is, emergency treatment is usually required, particularly the surgery.
Unruptured tubal pregnancy, expectant management. Only observation is done, hoping spontaneous resolution. Indications are initial serum HCG level less than 100 IU per liter, and the subsequent level are falling. Gestational size is less than 4 centimeters. No fetal heart rate, no fetal heartbeat on TVS. No evidence, bleeding or rupture.
That's it. So what do? We give conservative management. Go ahead.
Conservative management, either medical or surgical. Medical management. The only look for centers are methotrexate.
Sulfingosynthesis. Yeah.
And methotrexate, potassium chloride, prostaglandins, or actinomycin. Conservative surgery, that's linear salpingostomy. Linear salpingostomy, the same, okay.
No, one is salpingostomy, one is salpingotomy.
Bottom. Okay. Thank you. Segmental resection, fimbral expression, and then salpingectomy.
Okay. Salpingostomy, you are just looking at it. Then salpingotomy, you are entering, and then salpingectomy, you are removing it. Totally.
Other sites for tubal pregnancy. 1, peritoneal cavity, and then 2, cervical pregnancy.
Yes. We have come so far to this, then you have the complications. We are supposed to finish by 11:15. It's about 11:16 now. Now, the complications, you have about 1 in 1,000 ectopic pregnancies result to maternal death. It is serious. Untreated or mistreated ruptured ectopic pregnancy could give rise to a host of percentages of death. And when you say 8 to 12% death, somebody tells you, it's not much. But you come to think of it, you are in an environment and about 100 people die, give birth or so, and you have that number dying. It is much because it has to do with leaving other children untended with. So the majority of these deaths, we are told, and that's the most painful aspect, are preventable. They are preventable. Yeah. So read that one. Chronic salpingitis, infertility or sterility, intestinal obstruction could develop after hemoperitoneum or peritonitis. So it is very difficult to just sit down and say, oh, she came and had this problem. Oh, this must have, as midwives, any problem we see, we get to the root of it, to avoid anything. Thank you for listening. Our assignments, please, let's do it while I prepare for the other people now. God bless you.
Amen.
Thank you.
Hello. Bye.
Bye.
Thank you,
Mama.
so much.
Bye.
Anyway, Donya.